Give us a sort of a view down the road, if you will, of Dune Medical and where you all want to go with your technologies, and tease us a little bit, if you will, about previews of coming attractions from Dune Medical.
Certainly, I'd be happy to. There's really two things that I think are particularly exciting right now. As we mentioned earlier, the technology itself is particularly good at differentiating between the cellular characteristics of cancer versus other healthy tissue. So any area where there's solid tumor or margins may be important is something that is of interest to us. We've done some feasibility work in a variety of other solid tumor settings. Two of the areas that stand out that are kind of the most interesting and going to move along are both in the prostate, where there was actually preliminary feasibility results published in the journal Nature Online in September. Very high diagnostic ability of that device. And really in that application, the implications of a positive margin in a radical prostatectomy are pretty severe.
Yep.
In that that's a patient who now requires radiation where they wouldn't have otherwise. So I think that's a very promising application. The other area is an interesting application we've been looking at inside the breast biopsy space. And we've just had some of our early feasibility work back, helping provide additional incremental information on guidance during a breast biopsy to help sample the most interesting spots inside the breast. We believe that in the long run, this is something that has the potential to help impact the underestimation rates and the upstaging that happens as a result of not always getting the most interesting spots inside the pathology core.
Interesting. You want to elaborate a little bit more on that, on how you see that coming to pass? Or I don't want to get in, obviously, to any intellectual property issues or things like that, but I love the tease that you're giving both Mark and I. Anything further?
I'd be happy to. I like to draw the analogy that if breast cancer were hot and a healthy breast were cold,
yep,
it'd be pretty interesting to have a thermometer at the tip of your breast biopsy needle. Well, we know that temperature difference doesn't exist, but we do know that those electrical differences, the same thing that we measure with the margin probe, do exist. And so by providing that kind of guidance based on electrical signatures and electrical information we're able to measure at the tip of a biopsy device, we believe that during the process of the biopsy, we can really help provide information. If you took this core that you would have normally taken, and that's a certain level of, let's call it hotness,
sure,
but something adjacent to it was a little bit hotter, you probably want to know to take that additional core as well.
Wow, what's your reaction to that? I think that's pretty exciting, don't you?
I do, Jay, and Michael shared some of that information with me last week, and anything we can do to improve our discordance rate from what we expect on a biopsy and what we get, or anything that can help us resolve still the existing upgrade of not cancerous tissue, but hyperplastic tissue to early breast cancer or non-invasive cancer to invasive cancer. We know there are upgrades on needle core biopsies that exist. It's probably not any lower than 10%, even in the best of hands, these upgrades. So if we can eliminate that, we have a secure diagnosis immediately or from the first core biopsy, eliminating having to do additional biopsies. So as Michael said, if there is a technology that allow us to take the biopsy from the area of most interest, not just by imaging interest or palpation interest, but by using these other properties of cancer to pinpoint exactly where and target the area where we need to take the biopsy from, that would be very welcome. And I'm kind of excited about that.